I'm going to go back to kidney disease because I know, Peter, that's something you're really interested in, but let's stick with the cardiovascular events. You agree that SGLT2 inhibitors have a place
Oh my
for
God, yes.
cardiovascular
Yeah,
events?
yeah, yeah. I think that really revolutionized cardiovascular medicine, because now, when we see our patients with diabetes, we can no longer say, oh yeah, talk to your endocrinologist, or your diabetologist. We have to say, are you on that medicine if they have established cardiovascular disease? And if they're not, you have to ask yourself why they're not.
Even if the A1C is controlled, you
Even
still
if the
think there
A1C
may be
is
a benefit there?
Yes.
Okay.
In fact, you mentioned several trials. In those trials, there was no difference when doing subgroup analyses. There was no difference in outcomes when baseline hemoglobin A1Cs varied quite significantly, or even when drop in hemoglobin A1C varied significantly. Everybody responded the same.
Okay. I don't want to get too deep. Keep it kind of simple for me. Why these drugs work, Peter? What do they do?
They have an effect where they block an abnormal reclamation of glucose from the urine. So paradoxically, in diabetes, there's actually greater amounts of glucose in nascent urine. All glucose, by the way, is filtered. It ends up in the urine, and then the body calls it back. But in diabetes, more of the glucose is brought back into the vessel. So the drugs block those channels, but they also are blocking sodium transport at the same time. So glucose and sodium go downstream. There probably is a whole myriad of effects of feedback between the tubules and the glomerulus. The glomerulus initially drops its filtration a little bit. So GFR actually drops on these drugs a little bit, but then it's much more sustained over time. And as Chris pointed out, there's actually less progression of proteinuria, there's less doubling of the serum creatinine, and there's less cases of end-stage renal disease. So there looks like there's a bona fide renal protective benefit. There's a great search to explain deeper mechanisms. For instance, there is homology of the SGLT2 channel with what's called the sodium hydrogen antiporter channel. And this is a channel that's been a drug target in prior clinical trials of other attempts to try to protect the myocardium. So there's great homology. There's now been binding that's been demonstrated. So this may evolve into a story of a pleiotropic effect. This class of drugs does more than just lower hemoglobin A1C.
So it's not just about urine and having more urine put out. There's some other things metabolically that may be going on.
Yes, and this change, while these channels are located in the kidneys, and some of these channels are also in the gut, that the body, once it gets into a mode of losing glucose, there's a variety of changes. So there's a shift towards ketone metabolism as an example. There's changes in, as Chris pointed out, body weight. So it's interesting, patients lose calories, but they don't seem to reconsume those calories and maintain body weight. In all the studies, body weight comes down, blood pressure comes down. It really is a very, very interesting development.
Another point in the kidney protection is that this is on top of the benefit from ACE or ARB. And it's different mechanisms. It's either side of the glomerulus, I think, that's helping. And so, we're looking like we are making an additive step, and we'll have two ways to help protect the kidneys that are under siege in diabetes.
But intraglomerular pressure must be part of it, because you see that same little drop in the GFR with ACE and ARBs, correct?
Well, as Chris pointed out, with ACE or ARBs, the reason why that drops is this efferent arterial this vasoconstriction with ACE or ARB is relieved, and so there's efferent vasodilation. With the SGLT2s, one of the theories is through tubular glomerular feedback that, in fact, the afferent arterial the input is reduced. So while the input's reduced with the SGLT2, the output is opened up with the RAS inhibition, and so therefore the glomerulus is very much depressurized.
So we're not taking away the benefit of the ACE or ARB. This is an additional benefit.
They appear mechanistically and clinically very complementary.